Good morning, everyone. I don't actually have any feedback on how people are joining, but I'm presuming that they are. And we're just going to wait maybe 1 or 2 minutes to let people trickle in, and then we're going to start officially. So I guess while we're waiting for people to arrive, Chingli, would you want to start sharing your screen, and then I can make an official introduction and hand over to Hannah.
Is that showing up
That looks good.
correctly? Okay, great.
Now I can see where the attendees are. So we have 135 at the moment, which is wonderful. And so welcome everyone who has joined, and welcome to those who are watching the video in the recording. I am very excited for this joint ASA and ESRS webinar on COMISA. I remember when I started working in this field, which was more than a decade ago in the COMISA field. I mean, there were a few researchers, I guess a handful of researchers that were interested in this topic, and it's wonderful to hear or see this explosion of this interest in this topic. So we have four speakers here today who are going to present some novel research and insights into their clinical practice. And I'm happy to have my co-chair here, Dr. Hannah Scott, who is the ASA representative. And I'll hand over to Hannah for the first introduction of our first speaker. Before I hand over, just to say that if you have any questions, then please use the Q&A rather than, I think the chat function isn't actually possible to do that. But please do add your questions to the Q&A section on Zoom. Hannah, thank you.
Thanks, Megan. Hi, everyone. It's fantastic to see so many people interested in this webinar. So I'm going to kick us off by introducing our first speaker today, Dr. Chingli Chaikotsa, who is a respiratory and sleep physician, as well as the clinical lead of the Sleep Health Service at Flinders Medical Centre. She is also an associate professor in sleep medicine at Flinders University in Adelaide, Australia. Her research expertise is in sleep medicine clinical trials with a focus on limited channel sleep study testing, community-based health service delivery models for OSA and insomnia, and optimizing OSA treatment. And her talk today is COMISA, the current state of play. Thanks, Chingli.
Thank you very much, Hannah. I'm going to start today with a talk about COMISA, the current state of play, just to set the scene before our other speakers. So I'm going to cover things like prevalence, pathophysiology, health consequences, impacts of therapy, barriers to treatment, and research priorities. So we know that obstructive sleep apnea is a condition characterized by repetitive upper airway obstructions during sleep, leading to increased arousals, sleep fragmentation, and intermittent hypoxia. Whereas insomnia is a condition that is characterized by difficulty initiating sleep, maintaining sleep, and or early morning awakenings despite an adequate opportunity for sleep that is associated with daytime impairment. For example, symptoms of fatigue, poor concentration, and or poor mood occurring at least 3 nights per week, with chronic insomnia being defined as the presence of symptoms for at least the last 3 months. There are patients who, however, who have co-occurring obstructive sleep apnea and insomnia, and this is where the term COMISA comes from to describe this comorbid obstructive sleep apnea insomnia condition. So co-occurring sleep apnea and insomnia was first described by Gillimanale in 1973. Since then, we've seen an exponential increase in interest and literature on the topic of COMISA, particularly in the last 2 decades. There were 2 studies published in 1999 and 2001, which reported high prevalence of co-occurring OSA and insomnia. We then started seeing increased number of small treatment trials, then review articles, increasing the awareness of COMISA, with the term COMISA actually coined in 2017 by Sweetman and colleagues at the Adelaide Institute for Sleep Health. This has subsequently been followed by an increased number of randomised controlled trials, investigating the management of COMISA, epidemiological studies, and a number of review papers and systematic reviews and meta-analyses. So in terms of prevalence, we know that about 30 to 40% of patients with insomnia will have evidence of obstructive sleep apnea. Conversely, 30 to 50% of patients with obstructive sleep apnea will report having insomnia symptoms. And it's believed that up to 11% of the population have co-occurring obstructive sleep apnea and insomnia. An accurate diagnosis, however, may be difficult in patients with COMISA. Whilst patients may have symptoms unique to either insomnia or obstructive sleep apnea, there are shared symptoms, such as frequent awakenings, non-restorative sleep and daytime impairments, which can potentially complicate the measurement and diagnosis of each disorder in the presence of the other, leading to misdiagnosis or focus on only one condition rather than both. Furthermore, COMISA is a heterogeneous condition where different patients may present with different differently clinically. They may have different causes and mechanisms, and they may have varying treatment responses. COMISA is thought to have a bi-directional relationship between the obstructive sleep apnea and the insomnia. We know that obstructive sleep apnea leads to increased arousals and awakenings, sleep interruptions during sleep and poor quality of sleep that can lead to insomnia. And we know that insomnia is a state of hyperarousal, which can then decrease arousal threshold and increase ventilatory response, lead to an increased ventilatory response, which then leads to increased upper airway obstructions in a cyclical manner. We know that treatment of sleep apnea improves insomnia symptoms, and treatment of insomnia leads to improvement in OSA severity, and I'll go into more evidence about that shortly. So people with COMISA not only experience difficulties falling asleep and maintaining sleep as part of the insomnia presentation during the night, but when sleep is obtained, it is marked by frequent respiratory events, arousals and awakenings as a result of the sleep apnea. And so this combined effect of having insomnia and OSA can have a profound effect on daytime function, mental and physical health and quality of life. And there is a growing body of evidence showing that COMISA is associated with a higher risk of adverse health consequences than either sleep apnea or insomnia alone. So a number of studies have now looked at the association between COMISA and mental health, so depression, anxiety and stress. And this table here comes from a study that was conducted by my Australian colleagues, Lang and colleagues, published in 2017, where they studied a group of 700 Australian males and were able to demonstrate a much higher prevalence and severity of depression in those with COMISA versus men with only one disorder. And this other study, which was an integrative review of depressive symptoms in COMISA, have shown that there's an additive role of COMISA on depressive symptoms, and it appears to be the insomnia that has a more important role than obstructive sleep apnea on increasing severity of depressive symptoms. So this study was conducted by Lechat and colleagues using longitudinal data from the Sleep Heart Health Study, which investigated the potential association between COMISA and cardiovascular disease prevalence at baseline, as well as cardiovascular event incidence over a period of approximately 11 years of follow-up. And the participants were grouped into 4 groups: the control with neither sleep apnea or insomnia, OSA alone, insomnia alone, and COMISA. And in the unadjusted model, obstructive sleep apnea and COMISA, but not insomnia, was associated with an increased likelihood of cardiovascular disease at baseline versus control. And after adjusting for confounders, COMISA was associated with an increased likelihood of having cardiovascular disease at baseline. However, insomnia alone and OSA alone were not associated with an increased risk in baseline cardiovascular disease. There were about just over 4,000 participants where they had data to evaluate the association between COMISA and incident cardiovascular disease. And they were able to demonstrate in the unadjusted model that COMISA was associated with a twofold increase in risk of cardiovascular event incidence. However, after adjustment for pre-specified covariates, COMISA was no longer significantly associated with incident cardiovascular events. And the authors proposed that they thought that this was likely due to insufficient statistical power. So a number of studies have also looked at the association between COMISA and all-cause mortality. And this is data from 3 longitudinal studies from 3 major cohorts: the Sleep Heart Health Study, the NANS study, and the Wisconsin Sleep Cohort. And people with COMISA have been found to have approximately 50 to 70% increased risk of all-cause mortality compared to people with neither disorder. And insomnia alone and OSA alone have not been found to be associated with increased mortality risk in fully controlled models. Also, there have been a number of studies investigating the effect of insomnia symptoms on CPAP acceptance and use. So these graphs here were showing results of a study where people with COMISA had reported reduced rates of CPAP therapy recommendations from their physician, lower rates of CPAP acceptance, and reduced nightly CPAP usage, particularly in those with more severe insomnia. This study here came from results of a randomized controlled trial involving 145 patients to investigate the effects of CBT-I on OSA severity, controlling for sleep stage and posture. And they found that compared to control, CBT-I led to a 7.5 point greater AHI reduction across sleep stages and postures, reduced awake after sleep onset, and a reduced number of awakenings. And they proposed, the authors proposed that the mechanism for this may be that consolidation of sleep leads to reduced sleep-wake transitions, and or that bedtime restriction therapy may potentially increase homeostatic sleep drive, leading to an increased arousal threshold. So this here is the results of a meta-analysis of 9 studies measuring the insomnia severity index and changes pre and post CBT-I. And studies have shown overall that CBT-I is associated with large improvements in insomnia severity, and this appears to be effective in both treated and untreated obstructive sleep apnea patients. So does CBT-I improve CPAP acceptance and use? And there have been at least 4 randomized controlled trials now conducted looking into this question. So they have, however, had mixed results, but there are some key differences between these studies that are demonstrated in this table here. Firstly, the first study published in 2018 utilised a CBT-I booklet, and this had a negative result, and they showed that there was low adherence to this CBT-I booklet compared to in-person CBT-I that was delivered in some of the other trials. Also, the studies which did show that CBT-I improved CPAP use, patients were recruited from sleep clinics and had more severe sleep apnea than AHI, at least 15 events per hour, compared to the study by Ong and colleagues, where they recruited patients from the community and there were more patients with mild sleep apnea in those groups. Also, it's unclear at this stage whether online CBT leads to an improved CPAP use, and Alex Sweetman will be talking about some of the research he'll be doing to investigate this further. So there are currently a number of barriers to effective management of COMISA. As I mentioned earlier, there's significant heterogeneity in terms of clinical presentation and treatment acceptance and response, and a need for tailored management approaches. There's currently a lack of understanding and awareness of COMISA by health professionals, and a lack of clear diagnostic criteria for COMISA. Current uncertainties regarding the health consequences, risk profiles, and best treatment pathways. There is limited access to sleep disorders services in many centres in terms of diagnosis and treatments for both OSA and insomnia, with some centres having quite long wait times to access health professional reviews, and also high cost of treatments may be prohibitive for many patients. There is a lack of skilled health professionals to deliver CBT-I. Currently, it's predominantly delivered by sleep psychologists with specialised training, and researchers are currently exploring ways to improve CBT-I access, including training of healthcare professionals other than sleep psychologists, such as GPs and nurses within primary care to deliver CBT-I, and also use of strategies like brief behavioural therapies and offering online CBT-I programs. And there is a lack of a coordinated multidisciplinary approach in many centres. So in terms of research priorities for the coming years, we need further studies looking at prevalence of COMISA in specific populations, such as in primary care and paediatric populations. We need to have a better understanding of the bidirectional relationships between sleep apnea and insomnia, which will help establish clearer diagnostic criteria for COMISA, define COMISA. We need to define COMISA phenotypes and their risk profiles in terms of morbidity and mortality risks, identify mechanisms for why OSA improves following CBT-I. We need to, this will help us to develop tailored approaches to management. I think we need to validate screening and diagnostic tools, including what the role of a lot of these novel diagnostic devices, such as neuroborn wearables, may be for identification of COMISA and help distinguish this from a sleep apnea or insomnia alone. We need to evaluate the effectiveness of different CBT-I components and modalities, for example, individual versus group CBT-I, therapist-delivered versus digital CBT-I. We need to assess the effects of CPAP and non-CPAP therapies, including medications, splints, posture devices, and upper airway surgery for OSA in patients with COMISA. We need to identify the best combination sequence of OSA and insomnia therapies for which specific groups to help enable tailored treatment approaches. And lastly, we need some further implementation research to develop evidence-based models of care that will improve patient access to sleep disorder service to enable prompt diagnosis and treatment. And I will end there. Thank you.
Thank you, Ching Lee. That was a fantastic presentation. And if you have any questions for Ching Lee, please post them in the Q&A. Ching Lee will be able to answer those during the session, as well as at the Q&A panel session at the end. I'll hand over to Megan now to introduce our next speaker.
Thanks, Hannah, and thanks, Ching Lee, for that wonderful talk. I'd like to now introduce Dr. Henny Jansen. Henny is a pulmonologist, somnologist, and the coordinator of the sleep-related breathing disorder program at the Sleep Medicine Center in Copenhagen. I'm probably not saying that correctly, am I, Henny? This is a multidisciplinary referral center that's in the south of the Netherlands, and that treats patients with complex sleep disorders. They manage sleep apnea patients referred from other hospitals with complex obstructive sleep apnea, including obstructive sleep apnea combined with other sleep disorders such as insomnia, COMISA, and patients with central sleep apnea. Henny, would you like to start sharing your screen with your slides?
I'm so sorry. Maybe we can go to the next speaker.
Or we could maybe do you want to send me your slides, and then Hannah, do you want to go through the Q&A for Ching Lee, and then Hannah, Henny, if you want to send me your slides, and then
I will send them. I will send your slides.
Great, thank you.
Thank you both. Ching Lee, are you still there with us?
Yes, I am.
Perfect, thank you. We do have a question that's come through from Anna. Her question was, in your opinion, what can be done to improve accessibility to CBT-I for patients with insomnia or COMISA?
Right, thank you so much for that question. Yes, so our research, my research team have been very much interested in developing simplified models of care for both obstructive sleep apnea and insomnia within primary care settings. So I mentioned training health professionals other than psychologists to deliver CBT-I and also provide OSA diagnosis and management. So we've been doing some randomized controlled trial, teaching GPs and practice nurses to deliver brief behavioural therapies, offering online CBT-I as an option as well. And I think we need to, we're awaiting studies to see what the impact of digital CBT-I is on COMISA as well. So I think, they are some important strategies, improving just general awareness of COMISA as a problem. Alex Sweetman has been doing a lot of work with our professional sleep association in Australia to improve awareness amongst health professionals that provide sleep disorders management as well.
I'll unmute myself. Thank you, Ching-Li. We also have another question about advice on CPAP in relation to COMISA. So is there a place where we can find practical information on CPAP? And I guess we can extend this to CBT-I as well, specifically for people with COMISA.
I'm not actually sure. Alex, I mean, we've got, in Australia, we've got Sleep Central. There's a website where there's, we can direct health professionals to resources for both obstructive sleep apnea and insomnia. I don't know, Alex, have you divided that into, have you focused that into COMISA, or is it still divided into OSA and insomnia?
It's still divided. That's exactly what I was going to point people to as well, Ching-Li. So sleepcentral.org.au is a government-funded information and education resource, sort of tailored for primary care clinicians, but lots of different clinicians and also people with sleep problems and sleep disorders can access it. And it's sort of like you go as deep down the rabbit hole as you want with the information on there. There's no COMISA section, but there's a lot of relevant COMISA information both within the insomnia and within the obstructive sleep apnea topics. Yeah.
Yeah, fantastic. It's a great resource. Thank you both. Megan, are we ready to go?
We do. We are. I do have the slides now, so I will share my screen.
Excellent. Thank you, Alex and Ching-Li.
Penny, do you want to just say when you're...
Yeah, I'm so sorry for the technical difficulties, but thank you for sharing.
Multiple screens is always a challenge.
Yeah.
So if you want to just say next slide when you're ready.
Yeah. So good morning, everyone. Sorry for the delay. Thank you, Megan, for the kind introduction, and hello, everyone. So I want to talk in this presentation about COMISA patients presenting themselves in various ways in your sleep clinic. And in this presentation, we will dive deeper into the different phenotypes and biomarkers in COMISA that may help you in the integrated treatment approach in your daily practice. Next slide, please. And so the first phenotype I want to address is obstructive sleep apnea as the cause of insomnia. You see here the polysomnography trend of a 50-year-old male patient with treatment-resistant hypertension. And in the top panel, you see the hypnogram of this patient. And what you see is a lot of sleep fragmentation, but no prolonged periods of wakefulness. His complaints were, his symptoms were profuse snoring and fatigue during the day. His insomnia severity index was 12 out of 28, with 3 points for sleep maintenance problems, but his predominant symptoms were during the day. He had no prolonged awakenings during the night and no insomnia-related anxiety. And as you can see in the middle panel, you see a lot of hypopneas, and in the bottom panel, a lot of snoring, but no deep desaturation as is seen in the red line. His HI was 43, but his ODI was only 6 per hour. And next slide, please. We started this patient on CPAP therapy. Next slide, please. Yeah. And with CPAP therapy, his compliance was from the beginning really good. He accepted it easily, and his HI was very low, and symptoms improved, including the middle insomnia symptoms. And next, here you see the pathophysiological traits of insomnia. And when we look at the pathophysiological traits of obstructive sleep apnea, there are 4 traits that influence the occurrence of obstructive sleep apnea: increased upper airway collapsibility, the activation of dilating upper airway muscles, respiratory stability or the loop gain, and the arousal threshold. And these last symptoms are influenced by insomnia mechanisms, and each of these 4 endotypes are present in obstructive sleep apnea patients, but the importance of each trait is different in each patient. And insomnia is thought to influence these endotypes by increased hyperarousability and increased superficial sleep. Next slide, please. And just as an example of insomnia aggravating obstructive sleep apnea, this is the CPAP trend from a male patient, 75 years old, with an AHI of 65, and he had stable CPAP treatment for years. But at the end of 2017, he contacted our outpatient clinic, and he was worried because he saw that in the last months his AHI increased significantly, and he couldn't explain it. And we checked his medical history. There was no change, no medication change. His CPAP was functioning correctly. But after talking to the patient, he explained that he had 2 periods of extreme stressful events that caused him insomnia and worrying. And he saw subsequently an increase of his AHI. And when the stress diminished and his good sleep resumed, his AHI was normalized again, and patient was reassured. Next slide, please. So insomnia aggravating obstructive sleep apnea, and by treating the insomnia with CBT-I, as Ching Li just showed, it was shown that in 145 COMISA patients, CBT-I significantly lowered the AHI as compared to the control group by about 7.5 AHI points. Next slide, please. And this was recently confirmed by another group in 25 COMISA patients. CBT-I was delivered in a 7-week individual treatment, and subjectively and objectively, insomnia improved in these COMISA patients. The insomnia severity index improved on average from 18 to 8, and wake after sleep onset improved significantly. The arousal index improved significantly, and also the AHI was improved by about the same amount as by the previous study by Alex group, about 7.8 AHI points. So CBT-I improving insomnia, improving obstructive sleep apnea in COMISA patients. And these authors wanted to test the hypothesis that by consolidating sleep, the AHI improved, but also by influencing these 4 underlying traits of obstructive sleep apnea. Next slide, please. And they looked at the CBT-I effect on the 4 obstructive sleep apnea traits, and they didn't find any difference in the underlying traits upon CBT-I treatment, particularly also not in the arousal threshold. Next slide. As I've shown before, obstructive sleep apnea causing insomnia with no anxiety, just brief awakenings, that is improved upon CPAP therapy, and insomnia aggravating obstructive sleep apnea. And when the insomnia is improved, the obstructive sleep apnea severity is improved. However, most patients have a much more complex interaction between obstructive sleep apnea and insomnia, just as Ching Li showed. And I want to address 2 other patients. This is the polysomnography trend of a male patient of 40 years old. A single patient, had no bed partner, and he presented with severe insomnia symptoms. His EASI was 28 out of 28. He had initial insomnia, middle insomnia, feeling of no sleep at all, couldn't function, anxiety, stress. And the polysomnography showed indeed in the top panel initial insomnia, very fragmented sleep, superficial sleep, a lot of sleep stage transitions, prolonged period of wakefulness. But also you see in the saturation trend frequent severe intermittent hypoxia and a lot of apneas and hypopneas. Next slide. This is the polysomnography trend of a female patient of about 55 years old who presented almost with the same amount of insomnia symptoms, the same type of insomnia symptoms. She had also initial insomnia, middle insomnia, sleep maintenance problems, prolonged period of wakefulness at the end of the night. and really anxiety, worrying about the health consequences, couldn't sleep, had tried everything, she said. And this was the polysomnography. She was a bit frustrated. She said, I was so nervous about the polysomnography, I didn't sleep the night before. So that's the reason why I fell asleep here really quickly. But at home, I can't fall asleep. And again, in the top panel in the hypnogram, you see sleep fragmentation, periods of wakefulness, particularly at the end of the night. And here you see in the middle part of the slide, you see a lot of hypopneas, no deep desaturations other than when going to the bathroom or going out of bed. But the symptoms of this patient were almost the same as the previous patient. Next slide. So as Ching Li showed, these patients have a much more complex interaction between the obstructive sleep apnea and the insomnia, with the frequent respiratory-related arousals leading to cognitions, maladaptive cognitions, maladaptive behaviors leading to prolonged periods of wakefulness. And if we wait long enough and we don't address the COMISA patient early on, don't diagnose and treat the patient, then the majority of the COMISA patients will end up as these last two patients. Next slide, please. And when we look at prolonged awakenings, we studied in more than 300 patients, OSA patients, COMISA patients, and insomnia patients. And when we looked at the number of awakenings between these age-matched groups, we didn't find a difference in the number of total awakenings. But when we looked at the number of prolonged awakenings, and we saw a significant difference between the obstructive sleep apnea and the COMISA and insomnia groups, whereas the COMISA and insomnia groups had more prolonged awakenings of 5 minutes and more, and time in prolonged awakenings was longer in the COMISA group and more similar to the insomnia group. So next slide, please. And when we looked at 72 COMISA patients with HI-matched obstructive sleep apnea patients, we looked what happened after the arousals in these patients. And there was no difference in the number of total arousals nor arousals without or with autonomic activation. But when we looked at what happens after the arousal with autonomic activation related to respiratory events, we saw that the heart rate response was prolonged. There's an increased time of heart rate response after an arousal. The arousal here is the vertically dashed line, and in the clear bullets you see the COMISA patients, and you see that there's a prolonged time of an elevated delta heart rate response. Next slide, please. And so it seems that it's important to see what happens after an arousal in COMISA patients as compared to obstructive sleep apnea patients. And one marker I want to mention in this for this instance is the odds ratio product. The odds ratio product is a marker where is a continuous marker that measures based on EEG signals in a 3-second window, and I won't go into detail how the odds ratio product is measured, but it gives a continuous value of 2.5 means fully wakefulness and 0 means deep sleep. And even within the conventional sleep stages, the 30-second sleep stages, the odds ratio product can change and give an indication of the sleep depth propensity. And you can see that on the left side panel, where you see different levels of wakefulness, and the conventional staging would consider them all wakefulness, but you see the odds ratio product on the top panel is full wakefulness and gradually decreasing to microsleeps, drowsiness, and in each sleep stage the odds ratio product can be calculated. And the odds ratio product at the moment is used primarily for hypothesis formation and research, but just to see what happens after an arousal and to get a better understanding, I want to show you the odds ratio product at 9 seconds. And on the right side panel, you see two patients. The top patient, patient A, there is an arousal. And 9 seconds after the arousal, you see a drop in the odds ratio product. But in patient A, the odds ratio product lowers to an intermediate value, indicating light sleep after an arousal. When you go to patient B, on the bottom half of the slide of the figure, you see again there's an arousal with an odds ratio product of 2.5. But in the 9 seconds after the arousal, you see a significant drop in the odds ratio product to a low level, indicating a much quicker sleep propensity to deep sleep. And perhaps our first patient with the frequent short arousals and immediately falling back asleep is perhaps a patient with patient B, such as patient B. Next slide, please. And when we look at COMISA phenotypes, it's important to determine what the severity is of not only of the COMISA, but also of each of the underlying conditions. And in that, for that reason, I want to mention the hypoxic burden, the hypoxemic burden, as a measure of obstructive sleep apnea severity. On the top panel, you see the respiratory events, and on the bottom panel in the green, you see the saturation curve. And the areas depicted as A and B constitute the hypoxemic burden after each event. As of yet, there is no clear definition what the cutoff value of the baseline saturation should be. It could be the pre-existing saturation, or it could be the time below 90% saturation. And all the individual hypoxemic burdens after each event are added and divided by the total sleep time, and then you get the total hypoxemic burden. So if we go back to the few patients that I presented with, the two patients that I presented with the severe insomnia symptoms, our first patient with the severe intermittent hypoxemia has a much higher hypoxemic burden. Although the symptoms remain the same, I think that as a clinician, when you see patients with that high hypoxemic burden, and we know they have an increased risk of cardiovascular disease, I think that would likely influence your treatment strategy, and you start CPAP, I think, earlier rather than later, as compared to the female patient with the severe insomnia symptoms, where you might make another choice. Next slide, please. And when we look at the severity of the insomnia, the other part of COMISA, apart from the severity of the insomnia symptoms, it's also important to look at the objective short sleep duration. This is a recent cohort study in 786 individuals that were divided in 7 groups based on the fact if they had symptoms, insomnia symptoms, if they had obstructive sleep apnea based on a polysomnography, and if they had normal or short sleep duration based on a polysomnography. And short sleep duration was defined as shorter than 6 hours. And so they had 7 groups. On the top panel, you see what the groups are. They had normal sleep duration with more than 6 hours sleep, no complaints. They had short sleep duration, but no symptoms, no obstructive sleep apnea. They had insomnia with normal sleep duration, insomnia with short sleep duration, obstructive sleep apnea, but also comorbid insomnia and sleep apnea with normal sleep duration and with short sleep duration. And in a 7.5-year follow-up, there were 191 patients with incident hypertension. And as they looked at the multivariable adjusted odds ratio, they find that the highest odds ratio were COMISA patients with some insomnia with short sleep duration, higher than the obstructive sleep apnea patients, but also higher than the COMISA patients with normal sleep duration. Next slide, please. And finally, when you look at the COMISA phenotype, apart from the symptoms and markers that I just mentioned, it's important to know that, as Ching Li showed, there's a high prevalence of comorbidity, mental health, chronic pain, stressors, restless legs, cardiovascular disease, and these conditions, with the treatment of these conditions, will also influence the presentation of the COMISA patient in your sleep clinic, and you have to take that into account. Next slide, please. Thank you for your attention.
Wonderful presentation. Thank you very much, Henny, for that data-driven overview of the different COMISA phenotypes and highlighting how complex this all is. Just a reminder to put any questions in the Q&A and we'll answer them at the end of the session. I'd like to now pass over to our next speaker, who's Dr. Christoph Schöbel, who studied medicine at the Charité in Berlin. After a research stay at Harvard Medical School in Boston, he returned to Berlin to complete his training as a specialist in internal medicine, cardiology, and sleep medicine at the Charité. And in 2019, he was appointed to Germany's first university professorship for sleep medicine with a focus on telemedicine, and that was at the Essen University Hospital. His scientific work focuses on the health effects of sleep disorders and digitalization in healthcare, and he has also completed a master's degree in medical data science at the University of Aachen. So, Christoph, if I can ask you to share your slides.
For sure. Hopefully everybody can see the slides now.
Yes.
Yes.
Wonderful.
Okay.
So thank you very much, Christoph, and we're looking forward to hearing about COMISA in clinical practice from phenotyping to scalable digital CBT-I. Thank you.
Yeah. Thank you, Megan. Yeah. Thanks for the introduction. And dear colleagues, these are my disclosure of conflicts of interests. And I think if a patient cannot sleep, OSA can't be effectively treated. I think the sentence summarizes one of the most important lessons we learned over the past years. OSA treatment failure is often not a respiratory problem, it is a sleep problem. Insomnia symptoms strongly influence adherence and perception of therapy and long-term outcomes. I would like to give you some practice and lessons learned from Germany, and therefore it's important to know that in Germany the patient journey for OSA is highly structured and even defined by regulation through the highest body of German health policy. What does it mean? The diagnostic pathway is sequential. As you can see here, the patient suffering from a suspected obstructive sleep apnea diagnosis usually follows a stepwise pathway from screening to portable monitoring, the so-called polygraphy, and finally polysomnography before any OSA therapy initiation. While this structures ensures quality, it's traditionally focused mainly on the organic sleep disorder. The problem is in OSA should be understood as a lifelong condition. Our goal is not only to initiate any OSA treatment, but to find also the right treatment for the right patient at the right time, and also to help patients remain successfully treated over many years. COMISA plays also a central role in this lifetime management concept. For COMISA, the key step is screening. As you heard, we recommend systematic screening, for instance, by certified tools like the Insomnia Severity Index, as you know. Why is this important? Because any factors that interferes with OSA therapy should be addressed, and COMISA is one of the most important. Some preliminary data out of registries in Germany show a substantial proportion of OSA patients suffering from comorbid insomnia, and there might be several risk factors as shown here. For sure, there is a bidirectional relationship, as you heard also in the other talks before, and that raises an important clinical question. When is the optimal time to screen for a comorbid insomnia in a patient with OSA? Is it before initiation of an OSA treatment like PAP therapy? Is it in parallel when starting an OSA treatment like PAP therapy? Or should we screen after initiation of a OSA therapy? So this is a question we try to find out also in other projects like this big project in 4,500 patients with OSA. There we want to investigate also telemedical means regarding diagnosis and also therapy follow-up. And we know that COMISA assessment should accompany the whole patient pathway. So we should try to screen for COMISA on the whole patient journey. That's why a structured follow-up after initiation of an OSA treatment is also essential, because COMISA can also develop later in the disease course of OSA. Therefore, we introduce a structured follow-up called SOS, which is trying to identify patients with therapy problems. We not only want to focus on the objective outcomes like device metrics, but we also want to know what about the satisfaction of the patient and what about the symptoms left despite having initiated an OSA treatment. Therefore, we propose the SOS criteria to have a regular follow-up in those patients to find out those ones with problems with the OSA treatment, especially those ones with a COMISA. The European Insomnia Guideline clearly emphasizes behavioral treatment strategies. As you know, it is the first-line treatment, also highlighted in other national and international guidelines. And a major milestone was the inclusion of digital CBT-I into the European recommendations in 2023. This opened the door for scalable treatment models. Because there is a real problem. It's fine to have CBT-I as a first-line treatment, but please have a look on the situation in Germany. Insomnia is extremely common, affecting about 1/3 of adults, yet less than 1% of them receive a CBT-I. Instead, many patients receive hypnotic medications because the limiting factor has always been the access to trained therapists. We are quite happy to be in Germany the first who can use digital health applications, so-called DiGAs or apps on prescription. What does it mean? There are several MDR certified digital programs available in Germany, and this is also true for chronic insomnia. Here you can see the first 3 listed digital CBT-I programs as apps on prescription. Those ones are certified as medical products, but they also have to show in randomized controlled trials that using the app is leading to a positive healthcare effect, in this regard to an improvement in insomnia symptoms. I can show you some one of the approval studies of one of the devices. As you can see here, to be listed as a DiGA, you have to show efficacy in randomized controlled trials, and with this you can show long-term reduction in insomnia symptoms, and also the majority of those ones in the intervention group having used the app achieved a remission with large effect sizes. We are also having real-world evidence data, real-world analysis, including thousands of users confirming these findings. As you can see here, out of 5,000 users of such a digital CBT-I program, they all show reductions in insomnia severity grades, improvements in sleep continuity, and most of them achieves remission in a large proportion. There are also randomized controlled trials in mixed insomnia populations, also including COMISA, to show effects of such digital CBT-I programs in patients with OSA and comorbid insomnia, showing similar results with even long-term effects. So I think regarding also practical use of those programs, we have to scale the importance and to find out the best way to address COMISA. And therefore, we desperately need projects like this, as we are driving in Germany, the so-called Somnolink project, where we try to merge structured sleep data. At the moment, those data are not merged, even not structured, but this is the prerequisite to find out the best ways how to screen the right patient and also when to start any treatment for the patient. Because our definite goal should be the right treatment for the right patient for the right period, and this is also true for patients with COMISA. So thank you very much for your attention, and I'm open for any questions, especially regarding the practical experience in this case. Thank you.
Thank you, Christoph, and nice to see the Zantman there for maybe for our Australian listeners and those who are further east who are about to go to sleep, not because of your talk, because of the time zone. But thank you very much for that wonderful overview.
Thank you.
In Germany. Again, the questions in the Q&A, and we'll get to those at the very end of this session today. I'm going to pass back over to Hannah to introduce our next speaker.
Thanks, Megan. Fantastic talk, Christoph. All right, it's my pleasure now to introduce our fourth and final speaker for this webinar session, Dr. Alexander Sweetman. Alex is a Senior Program Manager and Chair of the Psychologist Education Subcommittee at the Australasian Sleep Association and has academic status at the University of Western Australia and Bond University. He has expertise in insomnia, comorbid insomnia and sleep apnea, and CBT-I. Dr. Sweetman is leading an Australian primary care education and implementation program to improve the management of sleep health and sleep disorders by Australian general practitioners, psychologists, nurses, and pharmacists. Thank you, Alex. You're on mute, Alex.
How am I now? All good? Yeah.
Yep.
Thanks,
all
Hannah.
good.
Sorry that the bio was so long now. Thank you so much for organising this webinar. It's awesome to have a joint webinar in collaboration of the Australasian Sleep Association and ESRS. So also thank you to Megan and Hannah, but also everyone else behind the scenes that was pulling it together. And thank you everyone for attending. It's awesome to be able to present on COMISA and really brilliant to see such a large turnout. As Hannah said, I'm a Senior Program Manager with the Australasian Sleep Association. So my day job is to coordinate a large primary care education and implementation program. But the COMISA field has always been my sort of passion area and my hobby. And for this presentation, I'll present on some work we've been doing on clinical trials with a digital CBT-I program in people with COMISA over the last 3 years or so, as part of this sort of area of interest and passion. And as Hannah said, I have academic status at 2 universities here that have some research funding attached to those. There we go. Some of my conflicts of interest, the main ones being a staff member of the ASA, and I'm one of the co-developers of this digital CBT-I program that I'll talk about and that we've used in our clinical trials. It's called Bedtime Window, but we provide access to Bedtime Window for free, so no one's ever paid to access Bedtime Window, and it was all developed and it's coordinated in voluntary time, so we don't make any money out of providing this service either. Before I begin, I would like to acknowledge the Aboriginal and Torres Strait Islander peoples past and present as the traditional owners of the lands that I'm joining from and that a lot of us are joining from, who have lived here for over 65,000 years. As you can see in this map, there were over 250 different, really diverse and distinct language groups, cultures and laws throughout the country, and I'm joining from lands of Ghana and Paramount people. So this has all been covered perfectly by the other presenters. Cognitive Behavioural Therapy for insomnia, reasonable evidence now that CBT-I is an effective treatment in the presence of treated and untreated comorbid OSA. There's 2 clinical trials showing that CBT-I also can improve obstructive sleep apnea by a small amount, even in people that aren't using treatment for their obstructive sleep apnea. And as Ching Li showed, there's at least 4 randomized control trials exploring the effect of CBT-I on downstream acceptance and use of PAP therapy, with some mixed results there. So overall, seems to be a really effective treatment in the presence of obstructive sleep apnea. And as Christoph said, widely recommended as the first-line treatment that people with insomnia should receive. There's a big but. So using Australia as an example, we think there's around 3.2 million people with chronic insomnia in Australia, but really consistently across our epidemiological studies, same data or same prevalence estimate that Christoph presented, only about 1% of these people are actually accessing CBT-I. So a huge gap between what's recommended in the evidence-based guidelines and what happens in practice. This is due to a large number of reasons. So limited access to appropriate trained clinicians is definitely one, but also limited recognition of CBT-I, inadequate screening for insomnia, and limited reimbursement to access CBT-I in some countries as well. Digital CBT-I has been around for a long time. There's lots of clinical trials now and quite a few meta-analyses demonstrating that digital CBT-I, either self-guided or clinician-guided, is a really effective treatment for chronic insomnia and can improve comorbid mental health outcomes. And digital CBT-I options, there's potential that they can really rapidly scale access to CBT-I throughout the health system while additional clinicians are being trained. And this is true of people with COMISA as well, that digital CBT-I might fill a need and increase access to CBT-I in people with COMISA. But unfortunately, people with COMISA have really frequently been excluded from previous clinical trials of digital CBT-I. So most digital CBT-I programs have been developed and tested in people with insomnia alone, or people with insomnia and comorbid anxiety or depression. And a lot of the time have specifically excluded people with either suspected or confirmed obstructive sleep apnea. And there's a reasonable rationale for doing this. One, it might be thought that CBT-I generally, but also digital CBT-I, might be less effective in people that also have OSA. So the thoughts about secondary insomnia, the insomnia symptoms might just be a manifestation of the OSA, and that there would be little purpose in targeting and treating the insomnia directly. Maybe another reason that people with COMISA have been excluded from some of these trials are also about safety considerations as well. So as was mentioned early on tonight, or this morning if you're in Europe, bedtime restriction therapy, one of the most effective components of CBT-I, that reduces someone's time in bed temporarily to build sleep pressure, consolidate sleep periods, and so on. Really effective, but can lead to increased symptoms of sleepiness, possibly alertness failure, and risk of accidents, which we need to be really careful about in the context of COMISA. So all of this culminates in people with COMISA being underrepresented, I guess, in clinical trials of digital CBT-I, and very few programs tailored for this population. So with this in mind, I've worked with two close friends and colleagues, Dr. Chelsea Reynolds and Dr. Celia Richardson, over the last 3 years or so. And we've been really motivated to develop, test and refine our own digital CBT-I program, and we've called it Bedtime Window, and trying to build a program tailored for both insomnia and COMISA. This is our wish list on the left-hand side. Essentially, it's a 5-session program, multi-component CBT-I, quite interactive and personalised. So the more sessions that a user completes, the more we start to build a really comprehensive idea of their sleep and wake patterns. We're testing it as a self-guided and a clinician-guided program. And we're also conscious of stepped care models for insomnia and stepped care CBT-I models being around the corner. So we're trying to build this, or future-proof this, as something that can support stepped care type research as well. And part of the work applying this for COMISA is also thinking about some of the risk mitigation algorithms to try and reduce the likelihood of increases in daytime sleepiness during CBT-I, and potentially some of the risks of accidents as well. And finally, we're complete nerds, and part of the reason for wanting to develop our own was that we wanted to get into the really detailed stuff, tailoring and tweaking the fine-grained different components and content of a program as well. So depending on time left, I'm hoping to do a very whirlwind tour of 4 recent clinical trials that we've done with this program in different samples of people with COMISA. So let's see how we go for time. So the first study, initially we wanted to test the effectiveness of this program in people with insomnia alone before we started scaling up and testing in people that also had comorbid OSA. So the first question was, is it actually effective, safe and feasible in people with insomnia? So we actually excluded people with diagnosed OSA from this first trial. But as we know, about 80% of people with sleep apnea have not been diagnosed. So that means there were still a whole lot of people in this clinical trial that fulfilled higher risk sort of symptoms and risk factors for obstructive sleep apnea. So we recruited 62 patients with moderately severe insomnia symptoms. And then we used a screening tool developed by Ching Li and colleagues, the OSA 50, to divide these 62 patients into those with either insomnia alone or suspected comorbid obstructive sleep apnea based on symptoms and risk factors. And then we examined the effectiveness of this digital CBT-I program between those 2 groups. So on the left-hand side here, we're showing Christoph presented the Insomnia Severity Index, so that was quite convenient. This is change in Insomnia Severity Index scores from baseline to 8-week follow-up, which is post-treatment, and also a longer 16-week follow-up between those with insomnia alone in blue and those with high-risk COMISA in purple. So the first thing to note is that there were reasonably large and sustained improvements in insomnia severity in both of these groups. It sort of looks like those with COMISA actually experienced a greater reduction over time compared to those with insomnia, but there was no statistically significant difference. So the take home here is that both of these groups showed a large and clinically meaningful improvement in insomnia symptoms sustained over time. And then on the right-hand side, we also did use the Epworth Sleepiness Scale during each week of the program to track changes in daytime sleepiness as different components of CBT-I were introduced and titrated. And it was nice to see this flat line for Epworth Sleepiness Scale scores until about session 3, when ESS scores started to decrease in the COMISA group, the insomnia alone group having quite low. It is worth noting that both groups had reasonably low scores overall, so a ceiling of 7 is the point estimate here. So we were more confident in the effectiveness and safety of the program in that pilot sample. So we moved to a randomized controlled trial next in people with comorbid insomnia, and this time a physician diagnosis of obstructive sleep apnea. So this is a pilot randomized controlled trial. These 30 patients were randomized to either bedtime window or a digital sleep education, our control group. And then after that post-treatment 8-week assessment, the control group were then provided access to the bedtime window program, and both groups were followed to 24-week follow-up. So again, showing change in ISI scores over the course of the study. So compared to the digital sleep education group in purple here, those in the bedtime window condition showed a fairly large and sustained improvement in insomnia severity index scores, which was awesome to see. And also after the control group were provided access to bedtime window, they then showed a similar degree of improvement in insomnia symptoms, maybe a slightly slower improvement for some reason, but there was no between group difference in ISI scores at either the 16 or the 24-week follow-up. Across these different RCTs and studies, we also observed large improvement in mental health, daytime functioning, so fatigue and sleepiness scores as well in this study. So trial number 3, we started scaling up, so demand has really started increasing now. And we were spending quite a lot of time fielding requests and coordinating these studies with more and more patients coming in. So we wanted to recruit via primary care practitioners and still have general practitioners involved in the oversight of both patient referral and maybe ongoing long-term management as well. Like GPs already have rapport and relationship with their patients, and might be able to provide some of the in-person care to complement a digital program like this. So this is a trial that we're wrapping up at the moment and starting to analyse. This is the first time that I've presented this. Over the last 2.5 years or so, we've recruited around 370 general practitioners around Australia who have referred almost 1,000 patients with insomnia symptoms, of who 500 completed the online screening and consent, and around 400 were randomised into this study. And then the study design is very similar to the randomised control trial I just presented. So randomised to either bedtime window or digital sleep education, and the control group accessing bedtime window after that 8-week follow-up. So in addition to the randomised control trial structure of this study, again, at baseline, we also split participants into those with insomnia alone, suspected obstructive sleep apnea according to symptoms and risk factors, and also patients with a confirmed diagnosis of OSA. Some of the baseline data here. So about 3/4 of the sample had insomnia alone, and the remaining quarter had either suspected or diagnosed OSA. A couple of things to point out: slightly higher age in those with comorbid OSA, higher BMI as we would expect, a higher proportion of males in those with a diagnosis of OSA, and interestingly, slightly higher insomnia severity index scores. There's almost this dose-response sort of relationship coming from those with insomnia alone to those with suspected OSA and those with a confirmed diagnosis of OSA, which was interesting to see. So this is what we found. This is sort of a complex graph, but broadly the blue lines represent those in the digital CBT-I group, bedtime window, immediate access, whereas the purple lines represent those in the digital sleep education control group. And then we've also split within those groups, split participants in the dotted line into those with insomnia alone, the dashed line, those with suspected OSA based on risk factors and symptoms, and the solid line representing those with a confirmed diagnosis of OSA. So I guess a couple of the main take-homes are that overall the program was associated with larger reduction in insomnia severity compared to this sleep hygiene education group. And the other take-home is that the slopes are really strikingly similar between these three groups. They're almost perfectly aligned, the degree of improvement in insomnia symptoms that participants in the three groups are experiencing by 8 weeks. And these are sustained and a little bit larger by 24 weeks or 6-month follow-up as well. So about a 9 to 10 point improvement in global insomnia severity, regardless of the presence or absence of obstructive sleep apnea, which was really cool to see. What about adherence and completion rates? This is a really important question that comes up for digital interventions and self-guided interventions. So we can combine data from all three of the trials here. Of the patients that are randomized into a bedtime window condition, about 60 to 87% complete the full 5-session program. But then I dug a little bit further, and most of that loss and dropout is because of patients that don't commence the program at all. So they don't really even click on the link to start the introductory session. And if we restrict just to the patients that actually start the introductory session, adherence goes up to about 80 to 90% of people that actually commence the program complete the full 5-session program, which has been awesome. I think I'm running low on time, but good acceptability type rates, reasonable or reasonably good treatment response rate. So these are some of the accepted thresholds to define treatment response. And almost 50% of patients using sleeping pills at baseline stop using sleeping pills by post-treatment, and those rates are sustained by 24 weeks, which is really cool to see. And then much more recently, this is the brand new trial that we're starting any second now. So this is pending the final steps of ethics approval. This group of investigators, it's awesome to work with this group of investigators that have been conducting a lot of the COMISA research over the last few years, and some of the pioneers of the sort of recent COMISA field. But we've recently been successful with an American Academy of Sleep Medicine Foundation grant with the aim of implementing this digital CBT-I pathway into sleep clinic settings in Australia. So providing sleep physicians with a free COMISA digital CBT-I pathway so that they can identify patients with OSA who also might have insomnia symptoms and refer them to this program for free access to treatment. And this is really about seeing if this program stacks up in the real world, and also how we go about integrating CBT-I and digital CBT-I into clinical settings that have historically focused on the management or diagnosis and management of OSA alone. So I imagine we'll identify a lot of barriers and different system level things to consider here, but we're really trying to understand uptake, engagement and effectiveness with this pathway. So if there's any Australian sleep physicians listening tonight, reach out to me and we'll provide access to this pathway. And I think like maybe a couple of weeks, we should be up and running. I won't present, this is just a diagram of the study. It's very similar, but sleep physicians will be referring patients in, we hope. Thank you so much again for organising the webinar and everyone for attending. For many people that have participated in our different clinical trials with Bedtime Window, we've got an awesome consumer group and expert advisory group in the background, and obviously all of the collaborators working on this AASM trial, and of course the foundation for funding this trial. Yeah, thank you.
Thank you, Alex. Fantastic presentation. We have run out of time for this webinar session, but we might try and squeeze in a question that's come through in our Q&A, and perhaps our clinicians on the panel would be best placed to answer this one. So this is from Dr. Verma, who has said, thanks for the talks. They're a sleep psychologist from NARM, Melbourne, in Australia. Many of their clients with COMISA feel defeated and hopeless with managing their sleep challenges. Have you got any suggestions or anecdotes for supporting these people in real-world clinical practice? Maybe Ching Lee, would you like to have a go at answering that one first?
Sure. And I think this is where it's really important to have, to be personalising treatments and having a tailored approach, speaking to patients, finding out what their primary concerns are, understanding what their needs are and their preferences for treatment, also considering, if they're struggling with CPAP, considering non-CPAP therapy options, etc. Christoph, would you like to add to that?
No, completely with you.
Fantastic. All right. Thank you both. In the interest of time, we might leave it there. Apologies that we couldn't get to all the questions in the Q&A. It's been a remarkable session. So thank you everyone for joining us today for this joint webinar. We hope you've all enjoyed and learned a lot from this session. A huge thank you to our fantastic presenters for sharing their time and expertise with us. They were 4 fantastic presentations. I'd also like to thank my co-chair, Megan, the awesome ESRS and ASA teams behind the scenes who have been organising this session. And thank you everyone for engaging so much in this session today. We look forward to seeing you in future webinars. Thank you.
Thank you.
Thanks, everyone.
Thank you.
Thanks, everyone.
Bye-bye.
Bye.
Bye.
Bye.